We were going to be talking about chapter 43, which is nursing care of the child with a genitourinary disorder. All right, so the kidneys of children are large in size in relation to the stomach, and they're at a higher risk for injury. Their urethra is much shorter, so the risk for bacteria entering into the bladder, simply because it doesn't have very far to climb from the external to the internal, is very high. There's also a really close proximity from the urethra to the rectum, and often they're in diapers. So diapered children, we know you need to get in. Well, we don't know. There's some people who have never changed a diaper. So you really have to get into those folds and crevices and get the poo out. It goes everywhere. Get in there. Get it out. We wipe front to back, no matter what. Even if they're not in a diaper, if a child just is learning toileting and they're not very good at wiping themselves, they're going to have feces in their underwear, and that will travel its way across and get to the urethra. So teaching hygiene and proper wiping technique is really important. So in children, the glomerular filtration rate, which is literally the blood flow through the kidneys, how it filters through, it's slower in an infant. This puts them at a higher risk for dehydration. Their kidneys are not as able to concentrate urine, and they don't really reabsorb the amino acids until they're about 2 years old. Their bladder capacity, a newborn is 30 mLs. 30. That is 1 ounce. It increases to the adult size, which is 270 mLs, by the time they are 1 year of age. And the reproductive organs are immature until they are adolescents. Know the difference between the ureters and the urethra. When explaining this to a parent, they often think that ureter is the urethra. So being able to explain how one is leading from the kidney to the bladder and the other is leading from the bladder to outside the body is important. It's also important in being able to describe where an infection might be happening. Part of the reason why kids are more susceptible to trauma is because their kidneys, they're larger in relation to their size as a child and take up more of the abdominal cavity, and they're closer to the surface because there's just not as much fat padding. So it's easier to damage them physically. And their kidney function isn't mature until they're at least 2 years old. So in our health history, we're looking for exactly the same things that we always are: previous illnesses, surgery, family history, history of present illness, when did it start, what are the signs and symptoms, what cues are the parents seeing. When we do the physical exam, again, we go from the least invasive to the most invasive. The least invasive is inspection and observation. We're going to be looking at the skin for signs of itching or scratching. So pruritus, edema, bruising. We're going to look at the child to see if they are lethargic or fatigued, if they're having a rapid respiratory rate, or if they've already had level of consciousness changes and they're exhibiting confusion, if they have diaper rash, if they're constantly dribbling urine. We also need to look on the males for hypo or hyperspadias. This is a displacement of the urethral opening at the glans penis. Sometimes the hypospadias is on the bottom of the penis, the hyperspadias is on the top of the penis, and this can cause issues with urinating. We also need to look for discharge. When we're listening, there's not a whole lot that we can hear in the urinary system. So one of the things that we listen for is murmurs. With a child that has a renal disorder, they might have a murmur due to anemia. We're going to listen to their lung sounds to hear crackles and rails if they're exhibiting a lot of edema that we might see in like a nephrotic syndrome child. If you can palpate the kidneys, that's problematic. If you can palpate masses in the abdomen, that's also problematic. For labs and diagnostic testing, I just need you to know the specific ones used for the diseases that we're talking about in this section. So UTI, we're checking urinalysis and urine cultures. CBCs, BUN, electrolytes, creatinine, total protein, albumin. The urinalysis, we're going to talk about different methods of collecting that. And timed urine collections, like 24-hour urine collections, to look at the creatinine or the total protein. This slide is showing you different collection methods usually used on a diapered child. We use urine bags for collection of urine just for a urinalysis, but we also can use them for a clean catch. We can discuss in class on Wednesday how we do that. Voiding stimulation, I seriously doubt that you'd ever be able to maintain any form of sterility trying to catch a stream of urine on a baby. You would end up touching the skin somehow, so I've never done that. You can stimulate them to urinate in a bag or a catheter. When we are catheterizing children, we need to use the same aseptic technique that we do with adults. It is much more difficult because they are tiny, they are fighting you, and their openings are microscopic. Catheterizing a baby boy is usually a lot easier than a girl. Well, I guess even in adults as well, unless they're an uncircumcised male. That tends to pose a little bit of a challenge for a lot of new pediatric nurses or ER nurses. Suprapubic aspirates, we don't do that very often. I have never done it. I've never seen anyone do it. This is not a common practice. This is just listing some of the acquired or functional disorders that you might have or you might see. Obviously, we acquire urinary tract infections. Enuresis is bedwetting, and that is considered a functional disorder. Most of the time it's males. Most of the time they grow out of it by age 7 or 8. If they don't, that's when we might need to look and see if there are physiological issues creating this problem. Most of the time that it's self-limiting. Nephrotic syndrome and acute glomerulonephritis, hemolytic uremic syndrome, and renal failure. We're going to touch on all of those. I have created a board that I would like you guys to go to and look at. There's pictures and YouTube videos and some great resources for you to see some of these things. This is one of those slides where I want you to write the information. What is a urinary tract infection? That it should be pretty easy to find the answer for that. The most common cause of a urinary tract infection is E. coli. It's a pooper. Things that might increase the possibility of urinary tract infections are urinary stasis, when the urine just kind of sits in the bladder after they void and it doesn't actually go anywhere, and decreased fluid intake. That allows for a drier environment and you're more likely to have some bacteriums climb up all those areas. The incidence of UTIs in children is about 8% in girls and 2% in boys, and it's really common in most infants and young children. During infancy, we do see it more frequently in males than females. Greater than 1 year old, it's more common in females, mostly because the shorter urethra allows the bacteria to climb up easier and quicker to the bladder. So we have to be very careful with education for the families so that they know the appropriate way to wipe and clean their children. Also, another problem is bubble baths. Remind me to talk about that in class. Some of the signs and symptoms or cues that you're going to see: infants are going to have fever, irritability, vomiting, possible failure to thrive, and even jaundice. We see babies come in looking really crumpy when they have UTIs. In an older child, fever, vomiting, they're going to be able to complain of the actual pain of urination. With an infant, you might see them cry, and then that's when you know you need to change their diaper. So they're letting you know it burns or stings while they're peeing. The older child's going to have frequency, hesitancy, urgency, and or pain. One of the complications of a UTI is pyelonephritis. This is when your kids come in looking especially crumpy. It is an ascending urinary tract infection, which means it goes up the urethra into the bladder, then up from the bladder through the ureters and into the kidneys. The kidney becomes pretty swollen and they're very unhappy. These kids look not great, and they're buying it sometimes a 5 to 7 day hospital stay. The therapeutic management is either oral or IV antibiotics for 7 to 14 days, although some evidence-based practice has shown that 2 to 5 days of antibiotics is just as effective. So it could be possible that we are over-treating with too long of a duration of antibiotic therapy, and that's going to cause some problems in the future, right? Some resistance, things like that. We do cultures to determine the organism when we are managing UTIs. We will usually start them, if we suspect a UTI, we'll start them on a broad spectrum antibiotic, and then once we've got the culture, which takes 24 to 48 hours to fully grow out, and parents are always anxiously awaiting it, and you usually don't get them over the weekend, which is horrible. Once we've found out what the organism is, then we can drill down a little bit more with the antibiotic therapy. We want to increase these children's fluid intake, and we want to manage their fevers. If they're younger than 3 months, they're usually admitted for IV antibiotics because they often can't tolerate the amount of oral antibiotics that they have to have. If they are vomiting or if they're toxic appearing, we have to admit them. The nursing management, we want to eradicate infection, provide comfort. Some of the ways that we can provide comfort is by keeping them clean and dry, giving them heating pads on their bellies to help with any of the pain from spasms. And we want to let them have warm sitz baths as often as possible, and because that actually makes them urinate with less pain. And you can look up the education that we would give to families on page 1567. The pathophysiology of nephrotic syndrome, otherwise known as minimal change nephrotic syndrome, is a lot. It is that the membrane in the glomerular filtration system has become bigger and more permeable than it should be, and that allows really large plasma proteins to flow through that should basically be left in the body, but now they're flowing through into the renal collecting tubules and they're being let out of the body. So this creates an abnormal loss of protein in the urine. There's 3 different forms of nephrotic syndrome. There's a congenital form, a secondary form, and an idiopathic form. Secondary means it was brought on by something else, and idiopathic means who knows. Again, this is more frequently found in males than females. What are you guys doing? What is occurring? You guys get all of the good GI stuff and all of the horrible GU stuff all together. 70% of nephrotic syndrome cases are diagnosed before a child reaches age 5. These kids exhibit cues of nausea and vomiting. They develop a very recent weight gain. They get periorbital edema that happens more often when they're waking up. They're weak, they're super tired, they're super irritable and really fussy. I've met quite a few nephrotic syndrome kids before they're diagnosed, and they are just like the Tasmanian devil. They're so mean. Some of the things that we do to diagnose nephrotic syndrome is checking the urine, seeing how many ketones they're spilling. If it's a super high number of ketones, then we look at their blood and see if the protein and albumin in the blood is very, very low. When they develop nephrotic syndrome and all those plasma proteins flow out into the urinary spaces and then out of the body, and the protein and the albumin in the bloodstream decreases, this changes pressure and it shifts fluid from the bloodstream into the tissues, which is what causes the overall edema, which we say is anasarca. So the kid develops anasarca, and then because they have a decrease in overall blood volume, because it's all spilling out into the tissues, their liver says, the kidneys say, "Ooh, I need to hold on to salt and water." And then holding on to salt and water makes the edema even worse. And then the liver says, "Oh my goodness, we're losing so much protein." And it starts making more lipoproteins. And then that leads to hyperlipidemia, and their kidneys can't get rid of the excess lipids. So it's like a horrible, constant loop of badness that just keeps happening with their body trying to reach homeostasis. Complications of nephrotic syndrome are anemia, infection, poor growth. They can develop peritonitis, thrombosis, renal failure. When we're managing them medically, we use long-term corticosteroid therapy. We should, as nurses, watch for any signs of infection, because using too much steroid can mask symptoms of infection. And then we want to give it with food so that we're decreasing the GI upset. Frequently in the hospital setting, we're giving corticosteroids through IV. Albumin can be given IV for the severely edematous child, and we give diuretics. Tell me which one you think we would give. Nursing management, we want to promote diuresis. We're going to monitor daily weights. We're going to monitor their output. We're going to monitor their ketones in their urine, and we're going to assess them for edema. We're going to prevent infection with prophylactic antibiotics. And we're going to educate the family. If they've just recently stopped corticosteroid therapy, they need to wait at least 2 weeks before receiving any live vaccines. We need the family to tell the doctor as soon as, or if they think their child has been exposed to chickenpox or another childhood disease. We want them to eat low sodium, low fluid, nutrient-rich foods. And we're going to give them emotional support for the amount of school and work that they miss and the way that they feel about their self, because they tend to look differently than other children. Acute glomerulonephritis, that's a mouthful. This is an immune process that injures the glomeruli. Again, it occurs more frequently in males than females, and it peaks around 5 to 6 years of age. Basically, this is an immune process that is in response to a group A strep infection. Remember when we talked about Kawasaki's disease and acute rheumatic fever? Acute glomerulonephritis is also due to these strep infections. They had the infection, and then a couple of weeks later, they develop inflammation, and the glomerular structures swell up and open, and then the function in both kidneys is messed up. Some of the cues that we're looking for: they have fever, lethargy, decreased urine output, severe abdominal pain, vomiting. Some of the labs we're going to do to check our hypothesis are looking at their protein levels and blood in the urine. So with the nephrotic syndrome kids, they had proteinuria, but they did not have blood in the urine. These kids, their urine is going to be usually looking like a glass of iced tea or cola. The darker it is, the worse it is. We're going to look at their SED rates. It's probably going to be high. And we're going to look at their ASO titer, which determines the strep or recent strep infection. We're also going to see these kids have hypertension and mild edema. Some complications of acute glomerulonephritis are that they develop uremia, which can lead to sepsis, obviously, and renal failure that can be either acute or chronic. In the medical management, some of the actions that we're going to take, we're going to try to maintain their fluid volume and manage their hypertension. So if they're a group A strep positive kid, we're going to treat them with antibiotics. We're going to give them antihypertensives like nifedipine because it is a calcium channel blocker. And calcium channel blockers prevent calcium from entering the channels, resulting in coronary vasodilation. So nifedipine is often used for renal causes of hypertension. We need to administer this with food, and we need to explain to the family not to have grapefruit juice or grapefruit containing products. Our nursing management of these patients is that we're going to weigh them daily on the same scale with the same amount of clothing. We're going to assess their blood pressure. We're going to maintain their sodium and fluid intake, restrict it. We need to restrict their sodium and fluid intake just like we do on the nephrotic syndrome kids. And we're going to look at their urine output, and we're going to note the color of it. Like I said, the darker the color, the worse the glomerulonephritis. If it's getting darker while they're hospitalized, you might need to let the doctor know. We're going to cluster their care and give them lots of rest. And don't use NSAIDs in patients that have questionable renal function, because NSAIDs can do something that's called an antiprostaglandin action, and that can make the glomerular filtration rate even worse than it already is. It's not going to be filtering the best, and then we give ibuprofen, and now it's filtering even less. Remember when we talked about the kids with the VSDs, the holes in the heart, and we could use prostaglandin to keep it open? Kind of think about that here as well, because an antiprostaglandin would be something that is closing something, right? It's a medication that can be given, or a hormone that's used that's closing something. So you're decreasing their glomerular filtration by closing those pathways. Enuresis, it's bedwetting. There's a couple different definitions. So this has primary enuresis. That's a kid who just has never been potty trained yet. So usually diapered children that haven't gone through the stress of potty training, they just pee wherever they are, and that's enuresis. Secondary enuresis, that's a child who has been potty trained that has bladder control for at least 3 to 6 months, and then now all of a sudden they're having urinary incontinence. Diurnal enuresis is when you are having, it's not bedwetting because you're not in bed. You're doing it during the daytime. So it's kids that are outside playing and doing their business, and then all of a sudden they've wet themselves. Nocturnal enuresis is nighttime bedwetting, but most physicians just use enuresis as the term for nighttime bedwetting. Anything else I need to say about that? These are some of the nursing actions you might take with kids with renal disease or GU diagnoses. We're going to make sure that their diet meets the guidelines medically that it needs to meet, such as decreased fluid and sodium intake. Some of them might need protein restricted diets, but we're going to try to give them as much as they can get that's as close to a normal diet. Strict isonos, you're going to give them diuretics. You're going to watch their potassium and calcium, and you might need to give them red blood cells because their blood volume is depleted. Some of these kids are going to need dialysis.